Respected peers and delegates, it is always easy to say than to do. Today, I am going to say something about the controversies in principle of orthopedics and how we do it. I am Dr. Pramod Lamichhane from Nepal, and my topic of presentation is controversies in orthopedics, tips, tricks, and solutions. So there is no field without a controversy. There is controversy in every field, in everywhere. So it does in orthopedics. What are some of the major controversies in orthopedics? Timing of surgery in multiple trauma. Some people say do early surgery. Some say wait for the vitals and the wound to be clear. And the modalities of surgery in open fractures. There are different modalities, and which to follow is still a controversy. Surgery in case of acute trauma with huge swelling. Some people go for early surgery, some wait for weeks or more than a week before the swelling subsides and go for surgery. And the time frame given for the union. Some people say the long bone fractures non-union after 9 months, but we see fractures uniting after 9 months, 1 year, or up to 2 years time too. So there are so many controversies in orthopedics. So I am going to highlight some of them in my topic. In research, methodologies, and in principles, case reports and case series also have a role. So we have formulated this through our own case series. With our own case series, we have also written a book called Orthopedics Practice in Nepal, Controversies, Tips, Tricks, and Solution, and How Do We Do It. And we have distributed it to all over our country and over all the continents by myself. So we know to speak on controversy is again a big controversy. So from the past around 100 years, the principle of trauma management is being evolving and changing. The first principle at the time of evolution during Second World War was just to save the life of a injured victim during the wars. But with the development of principles, technology, antibiotics, and others, the principle is also changing from saving life-saving era to limb-saving era, then prevention of infection, then now the principle later on should be early return to pre-injury status. It is no meaning that if the patient takes a long time to return to his pre-injury status and with a lot of cost. So the another principle should be the affordable cost in treatment in a country like ours, in developing countries and underdeveloped countries, because there is a lot of expenses in orthopedics and in treatment all over the world, even in the countries, in the developed countries where there is insurance facilities. That is also a big burden. There is no single gold standard treatment lasting for decades, and it is being changed all over. And we should follow the most reliable one out of many modalities of treatment. We can see the principle of AO is also changing. Previously, they used to say anatomical reduction, but now it is changed to anatomical reduction in joints and functional reduction in case of metaphyseal and shaft. And rigid fixation has been changed to stable fixation. So principles are changing, and we have to flow with. We have to go with this. This is one example. This is my own case. He had undergone spine surgery, and he came with this infection. The cause was unknown. The patient blamed us that you have done wrong. You are doing now. My wound is being discharged, and I am getting more trouble. What will be the cause in this case? Hospital factor, sterility, or the doctor's factor, timing of surgery, or the method, or the patient factor. We don't know the cause. But what we could see is that there is the implant is not the optimal. That was not made by us. That was from a company. But we thought that this was the culprit for the infection, and all the blames were for the hospital and the doctors. So the another case is this is a simple tibia fracture. It was treated by Ilizaru external fissure. Was it right to do the Ilizaru, or is it better for the patient, for his morbidity, for his early return to his normal life with other modalities like internal fixation with intramedullary nailing or plating? So this is also a controversy, and we should judge on this while treating the patient. And the timing of surgery in case of multiple trauma. People say that uh, in 1970s they used to do to early total care, do everything within the limited time frame. But later on it happened that these had more morbidities and mortalities. So they came to the principle of damage control orthopedics in 1990s. But in this also there were drawbacks. So what we follow is the middle path principle. Do as much surgery as you can in a safe period of time, uh, so that the patient get better early, and with less morbidities. So we don't wait for the damage control. And we also postulated that this golden hour means 6 hours within the trauma. What we say is, if we can do surgery as much as possible, if the anesthetic and the uh, patient's physiology allows, then it is better to do major surgeries within that time frame, so that the patient get early better and with less morbidity. So this is the principle we have been following for the last 15 years in our center in Nepal. So the principle of management of open fracture is also simple. What we follow is a debridement, antibiotic coverage, usually temporarily fix the fracture initially for a few weeks, then go for definitive fixation later on and prevention of infection. But what we say is that if we can do surgery early, if the patient arrives within 6 hours, and if we can do definitive internal fixation within that time, we can have good outcome with less morbidities, and the return to their life, return to their pre-injury life earlier. So these are some of the papers that we have been presenting all over in 2000. Uh, in 2012, I have presented this case in Korea, and in national conferences also I have been presenting the same principle of treatment all over. In 2018 in Seacourt in South Africa also I have been presenting the same thing what we have done, and this is supported by some of the literatures, and these are some of our case examples with early definitive internal fixation of open fractures with good outcomes in short period of time. So these are the papers in support of our literature, and this is my second presentation in this conference, and I have presented some of the cases yesterday. Yes. And the another is the controversy is early versus less surgery in case of use swelling. What people say is that if we do a surgery in case of swelling, then it may get infected, or it may be difficult to close the wound, and it may be more difficult or problematic. But what we believe is that why they say this is that it is difficult to close the skin. There will be further damage to the soft tissue with immediate surgery. And what they do is delay the surgery and temporarily manage the fracture by external fixation, traction, and later on go for definitive internal fracture. But these are our case series. We have done about more than 493 closed tibia fractures with close injury with swelling, or we have done surgery within 6 hours of injury, and we have got good results with that. What we say is that in a closed compartment, when the bones are scattered, then there will be stretching of the soft tissue, and there will be more damage to the soft tissue if we let it be there for long. So if we can reduce the volume within a short period, then the further damage to the soft tissues will be less, and there will not be any skin problem later on. This is what we think and what we do. And these are some of our case examples. This was the case at presentation, presenting to us what we did: close reduction, and it has a close reduction, internal fixation, and they have good results. And these are some of the papers in favor of early surgery. They conclude that there is no significant difference in infection rate. Hospital stay was less with early surgery cases, and they have less morbidity too. So the another controversy is the arbitrary term for the time for union. That's already I have highlighted. 6 months for delayed union and 9 months for non-union may sometimes mislead to our treatment. Because the fractures may unite. We have seen fractures uniting up to 3 years, but the morbidity should be less. If the patient is walking with some limp, and if there is only pain on pressure, and there are signs of union, and patient is not feeling, not complaining of that for his life, then we can continue the same treatment for long so that it unites. We don't have to do bone graft, we don't have to change the nail in between if there are signs and signs of union and patient is happy after 9 months too. And these are some of our cases. These were planned for exchange nailing and planned for bone graft at some centers, but we continued. When the patient followed to us, we continued with the same treatment, and there was union after 1 year too. So without doing any intervention in between. These are our cases, and what we conclude is we have seen the arbitrary term of 6 months for delayed union and 9 months for non-union for long bone fractures from the time of fracture treatment, because it should be have more justification. The time for fracture healing is different in different patient, and it should be individualized as to the patients. So this is the Houston team that I had a chance to do my fellowship in Netherlands in 2022, and this was how they were managing all trauma cases at Erasmus University. And our education system should not be like this. It should be more practical and more individualized, because only reading and applying that is not enough in orthopedics. The take-home message from my presentation is that there are lots of controversies in orthopedics. Should have a wide acceptance range in treating patients in orthopedics. A time-tested principle and personal experience case series are also a guide to the treatment for the individual doctor and institution. Availability of resources, manpower, and some patients' desire will guide the treatment plan in the country like ours in developing and underdeveloped countries. Thank you.